right, good afternoon. We're going to get started. We are so thrilled to have our first in-person event, well, not first, but first Bragbound event in a very long time as part of the Trauma Interest Work Group, part of the Tomato Institute, in person. So we're very thankful, and thanks to Amy for such a wonderful arrangement. If you all were here in person, you'll be impressed. So thank you, Amy, for a wonderful brown bag, like really high class lunch. Brown bag doesn't do it justice. So anyways, my name is Sangha Mathis Denny Zulu. I'm an associate professor in the Department of Psychiatry, clinical child and adolescent psychologist for families exposed to trauma and violence. I'm also the current chair of the Trauma Interest Work Group. So I'm here to introduce to you our one of our other trauma interest work group members, Dr. Liz Tung. Before I do that, I just want to talk a little bit about TIWG, the Trauma Interest Work Group. We are a group that promotes the scientific interdisciplinary understanding of trauma to improve the health equity on the South Side of Chicago and beyond. And we do this through education, scholarship, clinical care, community engagement, and advocacy. So that is the mission of our group. We've been in existence for a number of years, about 6 years, and have been recently added to the Men's Institute for the past, I think, 3 or 4 years. So just a few housekeeping things for those who are online. Please mute yourself if you don't mind. If you have any questions, Dr. Tung will talk a little bit more about asking questions when and where during part of the talk, but please use the raise hand feature or something in the chat. It will be better to use the raise hand feature so we can see it more easily. And then this event is recorded, so will be available on Men's Institute YouTube channel. And if you're interested in signing up for the listserv, please visit list.uchicago.edu and select Trauma Interest WG. So again, that's list.uchicago.edu and select Trauma Interest WG. And this is our last event for the rest of the academic year, and we'll start again in the fall. So thank you again, Dr. Tung, who is joining us and is a medical doctor and a social epidemiologist practicing internist in the section of internal medicine at the University of Chicago. Dr. Tung's research focuses on the impact of social conditions on health with a special interest in race, place, and poverty. She's participated in community-based strategies to improve health on the South Side of Chicago and the West Sides of Chicago as well, which has led to vested commitment to advancing health equity and eradicating disparities. Her research focuses on intersections between community violence, trauma, and chronic disease. She brings conceptual expertise and detailed knowledge of place-based measures of social risk and uses geospatial analytical methods, in addition to traditional clustered regression techniques in her quantitative work. Her work plays a vital role in bridging the worlds of violence epidemiology and health. Her K23 award, funded by the National Heart and Lung Blood Institute, examines violence as a social risk factor for metabolic and cardiovascular diseases. So we're going to hear more about that. And thank you, Dr. Tung, for coming.
Guys, thanks for inviting me to give this talk. I've actually never been in this space before, and I can't get over how beautiful it is. So really a pleasure to be here. Okay, so I'm a general internist and a social epidemiologist. And so for folks who might not be familiar with the world of social epi, we essentially study social risks for any kind of disease. And so rather than being focused on a specific disease entity, we tend to be focused on clusters of social risk factors. And so the social risks that I tend to focus on are violence, incarceration, and housing, all of which intersect in a variety of ways. Today, we're really going to kind of focus in on that violence piece. And to contextualize it a little bit, I just kind of want to share some early experiences that I had that kind of really laid the groundwork for thinking through some of these issues. So before med school, which is now about 17 years ago, I worked for a community development corporation in Lawndale, Chicago. Lawndale's on the west side. For those of you who are familiar with Ta-Nehisi Coates' work, he actually called out Lawndale as being the epicenter of mortgage redlining. But I actually came to Lawndale essentially from a community development lens. And, it was in Lawndale that I became acquainted with this place called Hope House, which is pictured here. Hope House is a residential program that helps people to re-enter society after prison. And in one of the first conversations that I had with someone at Hope House, a middle-aged man said to me that essentially he had been shot 10 times, but he survived. And then he went on to talk about the next 10, 20, 30 years of his life. And it was the first time that I really stopped to think about that longitudinal trajectory of someone who's experienced some really profound trauma, but then have an entire life to live after that. I think when we think about, gunshots and firearm violence, a lot of times we think about that firearm violence as kind of the end of the story. But for him, it was so early in his life course, and he had this entire decades and decades of life to live after. And so we talked about a lot of his triumphs over the years, but also a lot of his profound challenges. And so, some of those challenges included struggles with heart disease, he had 3 heart attacks, 3 stents placed, and also just chronic ramifications of trauma and anxiety. Later on in residency, my experiences with Hope House led me to the Rhode Island prison, where I did a continuity clinic for 3 years. And I was actually part of a special track where I got to do my regular resident clinic, but then also a community-based site. And so I got to do that at the prison. And one of the first things that I learned was that the lifetime traumatization rate for inmates is near 100%. And this was based on a survey that looked at criterion A measurement of trauma. And so it was based on life threat. And I actually got to see in a very literal way clinically how trauma was really the centrifugal force that just continuously perpetuated the cycle of incarceration and vulnerability for a lot of my patients. And so, a lot of my patients I actually would see multiple times. They would come into prison, they would leave, and then they would come back. And it was just kind of this cyclical exercise that was just really hard for them to break out of. So after residency, I did a master's program here in social epi, and I became really interested in this intersection between violence, trauma, and health. And because of my experiences in Lawndale, I was really oriented to the issue through a lens of neighborhood development. And incidentally, UChicago happens to be a great sociological institution that really pioneered research in neighborhood effects. So this kind of became my methodological frame to start digging into these issues. And so in the neighborhood effects literature, the Chicago School has 2 core assumptions that are relevant here. First, the places that we live in have direct and indirect effects on personal behavior and health. For example, we know that there's a 30-year life expectancy gap between North and South Side neighborhoods. And so if you kind of sit in that for a minute, if you're born in Englewood, your life expectancy is close to 60. If you're born in the Gold Coast, it's close to 90. And those neighborhoods are less than 10 miles apart. And then in the real world, these places are sociologically and economically differentiated, both by intrinsic and extrinsic factors. And so an example of intrinsic factors could be ethnic enclaves, where people differentiate based on shared language or culture, for example, Chinatown. And then an extrinsic factor could be residential segregation due to racism, which plays out through a number of policies, one of the most famous being mortgage redlining. And there's a really long tradition of neighborhood effects research, but something that myself and some of my mentors noticed was that the literature on neighborhood effects really lacked a cohesive conceptual framework for thinking about health and equity. So a few years ago, Marshall Chin and I, along with Kate Cagney and Monica Peak, we made this conceptual model based on the neighborhood effects literature. And in our model, a person's demographic context forms the foundation. So we illustrated race and poverty as some of the most influential demographic factors. But there are obviously others. There's also gender, there's sexuality. And these demographic axes then intersect with the third axis of place to then compose the built-in social environment planes. So if you imagine this as a cube, the reality is that every behavioral choice that a person makes is somewhere in the 3D matrix of the cube. And they process influences from their built environment. And so that could be green spaces, businesses, grocery stores, their social environment. So that can be crime, interpersonal behavior, social cohesion. as well as their intersectional background characteristics, all to eventually promote or prevent healthy behaviors. So you can imagine all the different inputs from all these different directions flooding into a person. And you can imagine how challenging it can be to make healthy choices when there's a really large quantity of inputs that ultimately constrain those choices. So constrained choice theory is something that sociologists have been arguing about forever, but it's the way that we have decided to kind of situate the conceptual model into a framework of power and structural violence. Bird and Riker, who are really kind of feminist ideologists, defined it as this: social position and policies determine the options individuals have in making everyday choices that cumulatively impact their lives and health. And then Paul Farmer also talked about constrained choice. He put it this way: these questions get at one of the oldest and most fraught debates within social theory, the reticulated relationship between structure and agency. A view from below would ask how poverty, racism, and gender inequality come to constrain agency, the ability to make choices. From a Chicago School perspective, I would argue that neighborhoods are actually a very fundamental unit of constrained choice, in that there are physical, social, structural dynamics that all play out in the places that people live. And extreme constraints can actually extinguish that sense of personal choice or agency. Any questions, thoughts, things people wanted to discuss?
Just amen.
Yeah, thank you. This is so validating.
Okay, cool.
Great.
Yeah. So, those are kind of the theoretical frameworks that I use to think through what it means to live in a place where violence and trauma are common occurrences. What does it mean for a person's decision matrix to live in a block where shootings occur every weekend? And what does that ultimately mean for health? So I do want to kind of give us a really precise sense of the state of violence in the US. Over the past decade, violence actually has been increasing across the country, in every state, actually. This figure looks at fire mortality rates over the past 20 years. And we were at historic lows until about 2012 to 2014, when you start to see the steep climb through 2017 and beyond. A lot of you know that the climb skyrocketed during the pandemic. And a lot of sociologists think that this particular surge in 2012 to 2014 was actually a latent effect of the Great Recession, because we saw growth in extreme poverty despite recovery elsewhere, and kind of that growing inequality.
Part of it's suicide, right?
Yes, yeah. So it's only like 6 to 58% suicide, with about some 40-ish% homicide, and then the rest being accidental. But a lot of people actually fear that these trends are going to continue in kind of COVID recovery, as we continue to see kind of this growing trend in inequality in this country. Locally, we felt the impact of violence in Chicago as well. So this is actually taken from a community health needs assessment at UChicago Medicine, where our patients were asked what's the most important thing that's needed for a healthy community. And respondents actually rated safety and low crime as the single most important thing to them, with mental health access close second. So this is an issue that really matters to people. And it actually matters a great deal for health, and not just mental health, but physical health as well. The bulk of literature has really focused on two main pathways linking exposure to violence to health. Perceived safety concerns, for example, can reduce a person's outdoor physical activity or their ability to access resources. And then chronic stress and trauma can directly trigger hormonal and adrenergic pathways. This is the cumulative wear and tear on a person's body that is referred to as allostatic load, which Bruce McEwen elaborated in the 90s. Recently, there's actually been growing literature on the epigenetic impacts of stress and trauma. And so Scott Kelly is an astronaut who went to space, and catecholamine levels in space are apparently twice that of Earth. And so when Scott Kelly returned to Earth, his telomeres, which is a protein at the end of your chromosomes, were actually shorter than his twin brothers. And Scott subsequently developed heart disease, despite being so healthy that we actually shot him up into space. So growing research actually is very interested in the impact of chronic catecholamine elevation, which can come from stressors like violence and how that could have downstream effects in health. So I'm going to kind of go through some early epidemiological work quickly. How are we doing on time? Time is it? 12:23. Okay. So I'll go through this kind of quickly. In some of the early epi work that we did, we really just wanted to quantify the effect of violence on population health. So to do that, we did a lot of geospatial work to essentially map the proximity of crime and violence. And then we looked at whether or not there were population level differences in health. So some of the quick main takeaways, we adjusted for about 20 neighborhood level factors and still saw 53% higher odds of obesity, 25% higher odds of elevated blood pressure. We also individualized our exposures and geocoded somewhere around the order of 20,000 individual addresses to their proximity to violence and crime. And what we actually saw was that recurrent exposure to everyday violent crime, so that might be assaults or robberies, were more strongly linked to poor health outcomes than a single exposure to severe crime like homicide.
I have a question for because you work with King Cagney. Was this about the relationship between where the respondents lived or where they moved throughout the city?
It's where they lived, yeah. And we actually excluded people who moved in a lot of our studies. And I can kind of describe a little bit more about that in the next study. But interestingly, these findings mirrored the racial discrimination literature, which essentially says that it's recurrent chronic exposure to everyday discrimination that tends to be related to health and not these spurious encounters to severe or extreme discrimination. All of which really continues to point to that notion of allostatic load, that it's this long-term wear and tear that results from chronic and repeated exposure to stress that really seems to be the most impactful for health. So in the follow-up study that we did, we actually wanted to exploit that 2012 to 2014 crime surge, which actually allowed us to use longitudinal methods. So, here we excluded people who moved, and then we focused on people who stayed in the same place, but actually saw a change in their neighborhood level exposure to crime. And essentially, we saw that in neighborhoods where crime increased, we actually saw proportional increases in blood pressure that were comparable to high dietary salt intake. We also saw more missed clinic appointments as well as hospital admissions. And ultimately, the effects were not small. The effects were actually quite large on a population. So, the population-based work kind of really led to the study that I launched in 2017 to kind of dive into some mechanisms for why we're seeing these relationships. So we launched a two-part study in 2 epicenters of violent crime in Chicago. This is the conceptual model that was developed from the qualitative portion of the study. And it's a very busy model. We're not going to go through all of it. But ultimately, patients described a lot of mechanisms that kind of expanded the way that we think about violence and health. We realized that most prior work in the literature really focused on the individual, namely these perceived safety concerns or stress mechanisms. And if you recall our original conceptual model, that decision matrix, you really can't get a good sense of constrained choice without thinking about the social and built environments that inform those personal choices. So unfortunately, we don't have a ton of time to go through all of these mechanisms. We do have data and studies on each bullet, but 2 of the most notable mechanisms that emerged were social isolation and hypervigilance, which I thought that this group might be interested in because they are very closely connected to trauma. So in our focus groups, actually any questions or things people want to talk about first before I dive into these mechanisms?
Anything online?
I haven't seen any.
Okay, that's so in our focus groups, social isolation was by far the single most frequently identified theme. And so I want to share 2 quotes that stood out. One woman said, "That's really what's keeping me inside. I would like to come out, but I stay inside because violence is going on. I have arthritis. It affects it because you can't get out to walk on a day-to-day basis. That would help the arthritis. I stay in the house pretty much. Somebody else said some women will not go out at night. And this was actually a guy that said this. So if there's an event they've been invited to from 7 to 9, most of them won't go. If it's going to be dark when I'm trying to get back home, they're afraid. And that's because of violence. What it does is you become a true homebody. You stay inside. So social isolation and loneliness are topics that have gotten a lot of attention recently, especially with COVID. But even before COVID, it was a big deal. So a number of public health officials are calling it a health epidemic. In the UK, they actually appointed a minister of loneliness to address the issue. Vivek Murthy has a book on the topic that actually came out before the pandemic. And then, recently he's been tweeting about it a lot in the post-pandemic era and has written something new. But all of this matters because loneliness has been shown to be a key predictor of mortality, even commensurate to traditional risk factors like smoking. So some have estimated that being lonely is comparable to smoking up to 15 cigarettes per day, which is really astounding when you think about risk factors. And so what's the link behind violence? So the late and great John Cacioppo, he was a pioneer in loneliness research here at UChicago. He theorized that a hostile or violent social environment can erode the very foundation of social connectivity, which requires trust, security, and the feeling of being meaningfully connected. So just a few quick definitions to get us oriented. Social isolation refers to the absence of social contacts or opportunities. Some objective measures could be living alone, having few social contacts, infrequent social contacts, whereas loneliness is that subjective feeling of being left out or excluded. And that could be true even with plentiful social contacts. So while there are a lot of narratives and qualitative studies that highlight connections between violence and isolation, there were actually very few studies that have actually tried to quantify this. And so in our quantitative surveys, we essentially included an in-depth social network assessment from NHLBI. And the survey asked patients to list their network confidants one by one, which are defined as the people you confide in and share important things with. And then we asked patients to answer a series of questions about each network confidant. So we looked at social network characteristics, so the type of relationship or the frequency of contact, living arrangements, do you live alone, do you live with family members, social participation in community activities like volunteering, perceptions of social support, and then also loneliness, which again is that subjective experience. And, essentially we found that exposure to violence was linked to higher social isolation and loneliness, lower frequency of contact, lower perceived social support, and then substantially higher loneliness. Loneliness was actually twice as high in our sample of older adults living in high crime neighborhoods in Chicago compared to older adults in the general US population. And so 66% of our sample actually scored positive for loneliness. And then we took a closer look at loneliness by specific violence types. So we actually saw that loneliness increased in a graded fashion by the severity of violence. And so we get higher loneliness from indirect exposure to direct exposure, and finally to exposure with PTSD. You can actually see that we saw over 3 times higher odds of loneliness in those screening positive for PTSD. So there's an incredibly strong link between trauma and loneliness. But what I actually found interesting was that even with indirect exposure, so this was if you were a witness, friend, or family member of someone who died violently, we actually saw almost 2 times higher loneliness, which means that, violence not only affects the people who are directly targeted, but has these rippling effects for the entire community. Questions? Yeah.
Yeah, so indirect exposure isn't neighborhood exposure, isn't like.
Not in this survey.
Okay.
Yeah, it can be defined multiple ways, but in this survey, it was if you were a witness, you directly saw somebody die violently in your neighborhood, or if you had a friend or family member who died violently.
And direct exposure isn't dying violently, because then you can you have globally.
Yeah.
And so what is direct exposure?
It was essentially being robbed, assaulted, attacked. And there were a couple of other. Okay, those were. And then we also verified in our cohort that loneliness was associated with health behaviors. So, you know, we saw fewer days of fresh fruit and vegetable consumption, fewer days of medication adherence, more days of binge alcohol consumption and more tobacco use. And then this was kind of an interesting sub-study that we did. We looked at the subgroup of people who had a direct exposure to violence and scored positive on the Criterion A life threat question. And then we saw, you know, their odds of developing PTSD. And in this particular study, we were trying to compare essentially their network size versus their network size and proximity to kind of get at this question of, does proximity of your social networks matter? And essentially what we saw was that the size of your network actually doesn't make a big difference on your odds of PTSD, but the proximity of your network, having 3 or more confidants within 30 minutes from home, was associated with lower odds of PTSD by 71%. And so that was an interesting finding that we need to kind of explore deeper, because there are these questions of, you know, we are more digitally connected, social networks might be larger, but does that large social network in and of itself convey benefits or protective benefits for trauma? Or does it actually matter that you have your community actually accessible and in real life?
I'm curious how you measured 30 minutes. Like if this was like if you asked people, how would you usually travel to see this person? How long does it take? Or if you kind of type the addresses into Google Maps, thinking about like people who have cars versus don't have cars.
Yeah, so because it was a social network interpreter. They actually named all their confidants, and then we asked them, you know, how do you usually see this person? And so they could indicate like walking, car, public transportation, and then we say how many minutes does it usually take you?
Gotcha. So they were answering that directly.
Yeah.
That's cool.
Also just wondering too, I mean, just, you know, working with patients with chronic trauma and using the digital aspect is not always stable. And I'm not quite sure if that's, I don't know how much weight that would have, but just throwing it out there.
Yeah, like
You
the
can call the
digital
number for an
divide.
appointment and then it's like, okay, I can't reach this person to say that number doesn't work anymore.
Yes, yeah.
So, they may have enough data to communicate.
Yeah, no, that's actually a really good point. We adjusted for like individual levels SES indicators, but we actually didn't ask in our survey, you know, I think that issue of consistent access to technology is a big deal. But we didn't have that foresight when we put the survey together. Anything else?
This is great.
So another mechanism that was really prominent was hypervigilance. So a few quotes from our focus groups. Just the thought of being in the streets, you have to have your guard up. If you don't have your guard up in the city, in any neighborhood, then you're making a big mistake. Somebody else said, I carry a knife. I don't want to be a victim. Even when I go to church on Sunday, I got it on me because I'm on public transportation. I sit on the bus or the train reading my newspaper, but I have one hand on the paper, one hand on the knife. It's unfortunate that you have to live this way, but to be aware is to be alive. So hypervigilance is a state of heightened awareness and watchfulness, even when the immediate risk of danger is low. This has been studied extensively in veteran populations. It's one of the 4 main symptom clusters for PTSD. And it's been associated with these very specific consequences. We see upregulation of fight or flight, which is interesting to me with respect to that chronic catecholamine elevation. We see poor emotional regulation and also cognitive impairment. And the way some of this has played out in experiments is that participants might be shown a trigger image, for instance, a picture of an attack, and then they might be shown the word blue in green font. And in a hypervigilant individual, they actually have difficulty correctly reading the word as blue, which would be called a failed emotional street task. And so for this analysis, You know, in addition to looking at violence between community members, we also wanted to look at police violence, which is particularly relevant for hypervigilance. And when we did the study, we actually couldn't find any studies that actually asked regular community members about their experiences with police violence, with measurement of trauma from those encounters. So I think some of those population estimates will be a little eye-opening. Okay, so we wanted to quantify exposure to both community and police violence. And as a secondary objective, we wanted to look at the relationship between hypervigilance and physical health outcomes. So to do this, we measured exposure to violence using the brief trauma questionnaire. We also asked participants if they had ever been involved in a police stop that escalated to feeling like their life was seriously threatened. And these were classified as traumatic police stops based on DSM criteria. And then hypervigilance was measured using the brief hypervigilance scale, another validated tool. Asks about daily watchfulness, emergency planning, scanning your surroundings, and chronic fear. And then we actually took objective BMI and blood pressure measurements from the EHR to look at our physical health outcomes. So some of the just kind of like descriptive results of this, almost 60% of our sample reported exposure to community violence, either as a victim, witness, friend, or family member. That was associated with a roughly 6-point higher hypervigilance score. 30% of our sample reported exposure to police violence. And that was associated with 10 points higher on the hypervigilance scale. And that's out of 100. And then finally, 10% of our sample actually had exposure to a traumatic police stop in which they thought that their life was seriously threatened or in danger. And this was kind of like the most potent form of exposure. And we actually saw 20 more points on the hypervigilance scale, which is the highest score for any subgroup. So
Susan, I just want to point out, you did that study before George Floyd.
yeah, this was in 2017 and 2018. Yeah, I feel like we need to do updated studies in like the post-George Floyd area, but I mean, it is very, very interesting.
What's the population that you were surveying?
Yeah, so we did 2 epicenters. So we had a South Side epicenter, which consisted of the catchment area for U Chicago Medicine. And then we did a much, much smaller West Side epicenter. I used to work in Lawndale. And so we kind of used the Lawndale Clinic cluster as our second epicenter. And, for the most part, this is kind of Southside Chicago, UCM catchment area, and then Lawndale.
So these are people who are coming into the medical centers where they're being surveyed?
Yes, yeah. It's an address-based sample from patient populations. So for our secondary outcomes, we found that higher levels of hypervigilance were associated with higher systolic blood pressure by about 9 millimeters mercury, which is actually a really large effect size at the population level. So as a point of comparison, 10 points higher in older adults translates to 50% higher risk of stroke or heart disease. Okay, so just a couple of summary items. How are we on time?
12:40.
Okay, so we'll have some time to chat. So our kind of patient population from these 2 epicenters were at really high risk of violence exposure and health consequences. 1 in 3 reported exposure as direct victim, half as a witness or close friend or family member. More than 1 in 4 actually reported exposure to police violence. 1 in 5 screened positive for PTSD. We saw really high levels of social isolation and hypervigilance, twice the level of loneliness, and all of these things had kind of health consequences for disease management and outcomes. And so, I think this was kind of like a baseline study that really like informed a lot of the thoughts that we had about how to move forward. I think some of the practical implications for population health directly for UCM that came out of this, and this is kind of limited, but it kind of led to more questions about population level screening. So, violence for some reason is often missing from this larger conversation about screening for social determinants of health. I was actually on a panel for health affairs with Alan Whale, who is the editor, and he was actually saying that he's on a ridiculous number of social determinants of health committees and goes to a ridiculous number of conferences, and that none of them talk about violence. Essentially, all of those conferences talk about housing, they talk about food insecurity, and they really kind of leave violence out of the conversation. And so, that kind of really struck me as really missing this opportunity, because every health system is implementing social determinants of health screening. And so, the question is why? Why is violence left out of it? And I think to some extent there is this feeling like, well, what are we going to do about it clinically? But I think ultimately we are kind of missing a chance to identify a very specific risk and offer resources that could potentially help mitigate some of the consequences of those risks. Now, I know Brad and I have talked a lot about the lack of mental health resources. And so, there is that question of, if I identify PTSD in my patient, which might be 20% of my patients, where do we send them? And so I feel like that is something that just keeps kind of coming up over and over and over again. But I know Royce has been working with NIDA on increasing PTSD resources in PCG.
Big resources.
So, another thing is with our social determinants of health screeners, intimate partner violence is the only thing on those screeners. And so that's, the Centers for Medicare screeners, Medicaid Medicare screeners, the National Academy of Medicine screeners. There's really nothing that measures any other kind of violence, and there are so many other types. And then finally, screening for gun possession is just something we don't do in adult medicine. And so we actually did a qualitative study we're finalizing and trying to get out there about how patients feel about screening for gun possession. And honestly, these were some of the most interesting focus groups I've ever sat in. But yeah, I think there are a lot of reasons why we don't do it. There are a lot of reasons why patients don't want us to do it. I think there is a lack of understanding about how screening for gun possession might actually help from a public health standpoint. And so, that is just also a whole wide area of opportunity that is just kind of fallen by the wayside right now. Any thoughts, questions?
You kind of said this, but I'm curious if you have any intuition or hypotheses, I guess, from your experience about why these conversations are missing. And it makes me wonder if you said that your background started with working with inmate populations, and it makes me wonder if the conversations about violence have been sort of siloed as that's a criminal justice question. We don't think about that in medicine, but I'm curious what you think.
Yeah,
And,
no,
understanding that probably no one has the answer, but I'm curious what your hypothesis would be.
Yeah, no, I think you hit the nail on the head. I think a lot of people think that it is a criminal justice issue. It's a criminal justice problem. And I think a lot of people in healthcare more and more are saying, well, actually, if we treated it as a healthcare problem first, we wouldn't have the criminal justice problem. And so there's been a lot of evolution of thought in the area, I feel like in the last 10 to 20 years. But a lot of our patients, in focus groups would say things like, I want my doctor to be focused on my medical problems. I don't want them to be focused on these problems. Leave that to the police officers. One patient actually called it like clinical stop and frisk. They were like, why have my doctor stop and frisk me? Like the cops are already doing it. And so it's a very complicated thing.
Interesting.
I do think trust in the healthcare system has a big thing to do with it. And I think all of our qualitative groups were at UChicago. And so, a lot of our team conversations have been around, well, would this be the case if it was at this other health system where the trust bonds are a little bit stronger. So
Yeah, that's really interesting.
Is that distrust specifically around screening for guns or screening for violence exposure in general?
So it's more about the guns.
Yeah,
We did do side-by-side conversations. There are people who, so we did kind of quantitative surveys alongside the focus groups, and it was about a third thought it was acceptable to screen for guns, and 2/3 thought it was acceptable to screen for violence. And so it was more acceptable to people to talk, for their doctors to talk to them about violence, but
For everyone, it sounds
but not for everyone. Yeah. So
There's so many different questions you can ask, so so much depends on what it means to be screened for violence.
Yeah.
And also the way you frame to the patient.
yeah, and that was also a big thing in the conversations about guns. Like, if it was framed like we're asking everybody this question because there are opportunities for prevention of suicide, and possibly other forms of violence, that seemed more acceptable to patients. And so the way we're trying to frame our paper is, it is this question of acceptability of screening to people rather than, whether or not it should be done.
So I agree with the as the same thing as the
I mean, the gun possession issue is more for suicide prevention. I think it's mostly for suicide prevention.
Well, domestic violence too, I think.
That's
right? It
true. That's a good
increases
point.
more.
Yeah, that's good. And then also, people will screen in pediatrics. But the question is, a lot of times, grandma doesn't necessarily go to a pediatric visit with the kid, and then they have a gun at home, and then the kids are there every day. And so, I mean, there are a lot of public health benefits to screening for guns. I think the question about whether or not you can prevent homicide or, mass shootings, like, I feel like that's a conversation people are having right now. And that I'm really unsure about. But I think certainly for suicide, for domestic safety, there are a lot of reasons why I feel like we should be doing it in the adult space, but just aren't.
You can ask a question, but agree upon it. Just to be provocative. What if you found that gun possession is associated with feeling more secure?
Yeah. Yeah. So I mean, well, no, I mean, 18%. So in our larger quantitative survey, 18% of patients reported gun possession, but then 10% declined to answer the question. So we think it's higher than 18%. And then 98% of those patients said that it was for safety. And so it is one of those things where, it's clinically, the goal might not necessarily be to say, get rid of the gun. If they're in mental health crisis, I have told 2 patients recently to get rid of their guns, but maybe we just focus on safety in terms of having the gun at home.
But also,
There's also a big difference between having a gun in your home
Yeah,
and carrying
and
a
carrying,
gun
yeah,
for protection because you perceive that you need to carry it for protection.
right. Like the man on the bus who's got like one hand,
Right.
on his knife, like that level of hypervigilance. Plus the gun or weapon possession or carrying is probably not a good combination.
but also, right, to your point, I mean, if you ask smokers why they smoke, a lot of them say it manages their anxiety, but the research suggests that's actually not the case at all. Right? So I mean, they may think they feel more secure, but I think the data suggests that the presence of a gun in a home makes everybody less secure. And so along with that line, and I know the whole point of screening is because in a public health setting, you can't do everyone, but did you ask at all about acceptability for education? I mean, I feel like a lot of people are really shocked at the statistics of having a gun at home increases the risk, suicide mortality by X number. And so I wonder if you could reach people without singling them out for having. Do you have a sense of whether that would be more acceptable than screening?
Like a more broad education. effort.
Yeah.
Yeah, I mean, I'm sure it would be. I think like a lot of the qualitative themes that emerged about guns have had to do actually with like targeting and profiling. So I do think it's that like individual, that feeling of, right, you think I have a gun, like, you know, and feeling discriminated against.
Like if we're assigned the random screen. person,
Yes,
that
yeah,
kind of stuff.
exactly.
And pretty much no matter what you say, when you have a population that's been criminalized,
Yes.
and you ask them about something that's a crime.
Yeah.
It's problematic.
It is problematic. So yeah, it's a very complex thing.
I'm with you, though, so I think that that's just the- So, you know, not one. It sounds like maybe we need some destigmatize. Right?
Yeah.
On that note, I want to go back to some of these things. I'm wondering, why the conversation about violence is missing these academic prestigious fields is in racism. Because when you started opening up, it's not Pandora's box is there, but when you start opening up the conversation, it means it's bigger resources, the priorities have to shift. And maybe racism prevents that from happening. An epidemic will be an epidemic is prime example. So I just don't know, what are your thoughts?
Yeah, no, I think that's a really valid point. Yeah, I mean, I guess, well, like, what are your thoughts on that?
Well, But I mean, I'm not in those spaces because I am in other spaces where it is clearly racist. And I'm not an epidemiologist, I'm not in these conferences, I'm not, but it just begs the question, how, if you're an epidemiologist, how could it not be part of that?
Yeah.
And is it, again, I don't like the term implicit bias because the effect of it is still the same, whether it's intentional or not. But is it hard for people to talk about racism and to be anti-racist spaces?
Yeah.
You're doing work, that's great.
I definitely think that it is easier to talk about poverty and it's harder to talk about race and poverty. And I do think that violence is definitely a more intersectional space. And so, I do wonder how difficult it is for people to kind of, enter into that conversation without feeling like they're entering into a complex space that is not as easy to argue for, something like that.
Do we know much about the stigma of gun violence and violence exposure? Because I think there's a lot of anecdata that we all have, right? I mean, I was in a meeting with a potential donor around trauma, and the person was very clear that she only wanted to support trauma resources for people under 16, because if you were older than that, you probably deserved it, right? And that there is some link between victim and perpetrator, and so I feel, so to your point, it's kind of like that's a them problem, not an us problem. So it's all these really stigmatizing ideas around who, yeah.
And that's the space to do it because who buys policy to significant, right? So
But are there even any measures to get at stigma around gun violence like we have around mental
it's
health?
pretty
and-
aggressive.
Yeah, because it's so fun to do the measures, right? It's something you can whip out in just a month, right? Measure development. Sonia's been working on this great measure, but it is a long process. Yeah.
What's the measure?
Looking at historical trauma for our child and adolescent family populations exposed to chronic community violence, and they're not only coming into the clinic with just I got shot or with shot, but they're coming in with racism, they're coming in with poverty, they're coming in with all the legacies of historical trauma that impacts their station. No one's really having a conversation in a systematic way, and with our clinic being wanting to get better at that so we can not only address the trauma that brought them into the door, but also the other aspects that impacts talking about racism, talking about different factors, talking about how to subvert DCFS or housing system. Because I have a 9-year-old who's coming home and Section 8 won't allow him to be here because he's a felon. You know, like what do we do? But that re-traumatizes families. Yeah. So having those conversations and also raising awareness from people. A lot of them don't realize, some of them don't realize that what historical trauma is, and how it leads to their families, and how it's passed down. Just raising awareness takes.
So following up on that, and I don't know how much time we have.
Brad, you got 4 minutes.
So I just
4
want
minutes,
to be
Brad.
provocative. Related to this. So you've done all this incredible work showing that structural violence harms the people who are targets of it, right? You're doing it in an institution like all of us that is an agent of structural violence. You're doing it in communities that have been directly harmed by the institution. And the institution continues to directly harm. One of the things that people said in the community health needs assessment was access to healthcare and mental health care. That is something that this institution has complete control of. They can change how they deliver care anytime they like. So, as people who are trying to provide this care, I believe we should be advocating for reparations from the institution to the surrounding communities, starting with providing them with medical care.
Yeah, actually, I give them a clean talk about the trauma center as a reparation, but we can talk about that another day. But yeah, no, I mean, I think like I feel like we need to double the size of our like mental health care team here.
We need to 100 times it.
Yeah.
Yeah, I mean, like the need is so high. Yeah, and you know, as a primary care doctor who's trying to make referrals, like it's so hard. Like Nita had to come up with this crazy system so that we can like try to meet the demand.
And at the same time, we're being forced to withhold care from people in all sorts of ways.
Yeah.
Just
It's not hopeless though. It's not, you know, we've got.
that are open.
right, but some of it is if we keep saying this and more of us say it, then eventually that's how institutions get held accountable and take the names of slaveholders off their buildings.
Oh, actually, I did have one more slide. But this is a quote that I like to share is from one of our patients, which really actually very much speaks to what Brad was just saying. So when you come to this little nest egg university campus, they tell you, think about this, and you go back into your community where everything is just blowing up. And then you go back and they say, well, did you try this and that? My thinking is if you're living in an upscale neighborhood and you're driving your Mercedes Benz, and then you're going to ask somebody who can barely get $2.25 to get on the bus to come talk to you, it's just you're bringing two different worlds together. I don't think you understand what I'm going through. I know you got all the degrees, but I'm still living over here. You need to hire people who have a better understanding of what's going on in different communities. It was just such a good quote from our patient. So I'm excited with that.
I was just thinking about that with the healthcare. I mean, the mental health care in particular, because being in the department, we hear it's hard. I mean, we've got what, like 7 or 8 open clinical positions and another 8 approved. And it's really, really hard to hire people, in part because our university doesn't make the hiring process simple and easy. But even without that, it's a lack of good candidates. And then particularly candidates that could understand the world. I mean, there's a pipeline problem too. We need where I think racism plays a role, whether it's explicit or implicit, in terms of just not, some people can't afford graduate training where you don't make any money, right, to train to be a therapist. And so, I mean, I think we can go way back into education too and outreach.
Thanks so much, guys.